Hello, everybody. I'm Craig Norman, and I want to welcome you to tonight's presentation sponsored by Oculus. Tonight, we're going to be discussing about how you can expand your OrthoK practice with the Oculus Pentacam and Wave with one of the experts in this particular area, Dr. Ken Mahler. First, I'd just like to mention another initiative that we are doing at the moment called May I Interrupt? And that particular process is where we have an interesting show. I happen to be co-hosting it along with Dr. Jason Jedlicka, where each week we have two guests in an eye care roundtable discussion where we explore questions in the world of eye care and other topics of interest. And we combine that also with a bit of entertainment, if you will, that relates to the hobbies or other special interests of our guests. Please consider checking out either the online version of it or in the podcast form, as you can see with the codes in front of you by simply taking pictures of it. And now I would like to go ahead and introduce our speaker for this evening. Dr. Ken Mahler earned his doctorate in optometry from the Illinois College of Optometry and then immediately entered private practice in the Florida area. In Florida, he's participated in many different studies investigating contact lenses and accessory solutions. He publishes often and authored the first Wave Contact Lens Designer Certification Program and lectures extensively, not just on Wave, but other areas in the specialty contact lens world. Dr. Mahler is a member of the American Optometric Association, their Contact Lens and Cornea section, the Contact Lens Society of America, and is a charter member of both the OrthoK.network and the Orthokeratology Academy of America. Additionally, he's on the advisory board of the Gas Permeable Lens Institute, a fellow of the American Academy of Optometry, and a fellow in the International Academy of Orthokeratology, as well as a fellow in the American Academy of Orthokeratology and Myopia Control. He's also a fellow in the Scleral Lens Education Society and a diplomate in the American Board of Optometry. And in his spare time, he's now in the process of earning his diplomate in the Cornea Lens and Refractive Technology section of the American Academy of Optometry. All I have to say to all those credentials is wow. Ken is a very accomplished person, a terrific contact lens fitter. He's a great presenter, as you're going to find out this evening. And from my perspective, an all-around really great guy as well. Dr. Ken Mahler. Kenny, welcome tonight.
Thank you, Craig. Welcome to everybody out there. To anyone who had been here last night, glad you came back and coming back for another round today. I promised today to go a little bit slower than I did yesterday to go through this material. This material is going to be on the Pentacam and OrthoK. And I sat down and thought about this for a moment as to how to present this. And really, OrthoK, to some of the older practitioners who have been at this game for quite a number of years, really have thought about OrthoK as a prescription elimination device. Much more recently, in the last 5, 10, maybe even 15 years, it's become much more centered around myopia management. But I personally don't forget about the fact that this really is a form of prescription elimination and a way to really get people to see without any devices on their eyes. So let's move ahead along. And this is my disclosure. The only ones that pay me are Oculus and my patients. I do also do consult work for docs around the country, perhaps some that are even on the line right now. And that's where I take some of their patients and help them through on their cases to bring those cases successful. And I am currently involved with designing up a training session for Wave through Oculus to try and get more people to be able to utilize this fantastic software platform. All right, so let's start with the Pentacam. What is it? It's a rotating shine flow camera, and you can see at the bottom there are 3 models, and for OrthoK, all 3 models would be perfectly acceptable to provide the data that you would need to do OrthoK successfully, both initially to design the lenses as well as to follow the cases. It is a corneal topographer and tomographer, and it does image the anterior segment. So in addition to getting all that surface data that you would get out of the typical Placido disc-based topographer, you really do get an enormous amount of metrics about the cornea and the eye, in addition to just that particular information from the Placido disc-based system. Now, orthokeratology, what is this? Well, orthokeratology in a nutshell is intentionally and temporarily reshaping the cornea, utilizing a contact lens on some repetitive but limited wear schedule, inducing a change to the refractive status of the eye. And it's been like that for over 60 years. This is not something that's new. It's been around for quite a number of time. And I bulleted a list here of what we really can use orthokeratology for: reducing or eliminating myopia, reducing or eliminating astigmatism. To a lesser degree, for a lot of the OrthoK docs out there, reducing and eliminating hypermetropia, reducing and eliminating presbyopia. And so you really can take care of all of the particular ametropias that are out there utilizing OrthoK. And I think it's important not to forget that those are all potential orthokeratology patients, not just the young kids who you're concerned about myopic progression, which of course is the very next line I have there, eliminating or reducing the myopic progression of that eye. Also, it can be utilized to normalize some types of corneal irregularities. I have had many cases over the years where the best spectacle correction might be 20/30, 20/40, and when you do a topography on there, you can see it's because of some irregularity central on that particular cornea. And you can utilize orthokeratology to normalize that. And it's not uncommon that you could take a best spectacle corrected eye of 20/30 or 20/40, normalize the irregularity, and end up with a 20/20 uncorrected eye without anything. Those patients are incredibly happy to achieve that type of a result. Now, the very last item I put on here was something based on the theoretical work that underlies our application of orthokeratology in eliminating myopic progression. Is it possible that we can use orthokeratology to normalize the hypermetropic eye, get that eye down from some plus number toward plano? I had suggested that to some of my colleagues approximately 15 years ago, and as of yet, I have yet to see any data come through any of the researchers, and unfortunately, I'm not a researcher, so that's just my proposition out there. And hopefully maybe a researcher will come along and take a look and see if in fact we can induce growth of the eye, basically the opposite of what we're doing with the myopes. We have these hyperopic children, maybe +3, +4, +6, and can we induce growth on that eye so as to get them much closer to plano? That certainly would have a lot of value for those particular kids as well. Okay, now what's WAVE? WAVE's a graphical software interface, and it's really very important to understand that really that's all WAVE is. It allows incredible control in terms of designing and manufacturing the rigid lens, and you can do it one of 2 ways. You can do it by modeling from a theoretical surface, so you can put up a theoretical surface in WAVE and then go ahead and design up a lens, anything you would like to experiment with. Or you can model it directly from the surface of a patient's eye that you've measured clinically. And we're going to certainly talk about that later this evening. You can design up any type of lens: single vision, multifocals, corneal, sclerals, OrthoK, anything that can be thought of in a rigid lens, you can design up with Wave. It's a free-flowing platform that just allows you to control whatever it is you like to do with it. It is really important, however, to differentiate. Wave is not a lens design. This is not a pre-made laboratory offering. It's not a lens model that is offered by a laboratory. There isn't any predetermined or fitting guide for you with this particular platform. It is really only a piece of software that lets you talk to a lathe and tell the lathe what you would like manufactured. And so this elevates you from the fitting role, where you would typically take a fitting guide that's been put together by R&D through a lot of practical experience. And you can go ahead and design pretty much anything you would like. And in my opinion, this is probably the single biggest problem that Wave has had in garnering a much greater acceptance out there amongst the practitioners. Because although this is an incredible amount of control, it really does give you a lot of control to design a lot of plastic garbage instead of a lens that really performs admirably. And very last, I put on there, it is the most mature lens software platform out there. And I do believe that we really are going to be moving much more toward empirical software fitting as we do move forward. We are seeing quite a bit of that already starting to take place. And this particular software platform called Wave has already been around for 20 years. So it's had a great amount of evolution that's taken place in getting the software to function incredibly smoothly and reproducibly. Okay, so to summarize what Wave is, let's start with the eye. Corneal surfaces and scleral surfaces are not rotationally symmetrical. Anyone who measures these with corneal topographers and or scleral mapping devices can already see that there is a fair amount of asymmetry to these structures, and the E-values are varying along each of those radii. So what Wave does as a software platform is it divides the lens, the 360 degrees of the cornea and into the lens, into 24 15-degree pi wedge radial segments. Now, each one of those 15-degree segments is divided into 88 zones. So by using the topography of the patient as the guide, or if you would like to design up a theoretical lens, you can do this based on a theoretical surface. Wave gives you the ability to control each of those 88 zones in each one of those 15-degree pi wedge segments. Wave takes care of the math so that the lathe will be able to cut the lens and connect all of those different zones so you have a continuous smooth surface, both on the front and the back surface of the lens. So I've diagrammatically put up here a monocurve lens. A monocurve lens would be a single red circle. So if we thought about a single monocurve of, for example, a radius of 7.50 millimeters, any spot that you would measure on the back of that lens would have that same exact curvature. Now, Wave will go ahead and divide those 360 degrees into those 15-degree segments. And I've just labeled over there 30 to 45 degrees as one of those 15-degree segments. There are 24 of those going around the clock dial of the lens. Along that 0 to 30-degree wedge, you could see I've put in those striations, red and white ones, and there's exactly 44 reds and 44 whites there, to divide up that segment into the 88 sections. And so every one of those individual segments, those 88 along that pi wedge, and all 24 pi wedges around the clock dial here are under Wave's control and thereby under your control. So we have 24 by 88 zones. That gives us a little over 2,000 areas that are being controlled independently under Wave. By utilizing that, we can certainly match the back surface of this lens much, much better to the cornea. In fact, a better way to think of Wave is that we're capable of generating a rigid surface that can literally drape like a soft lens on a corneal surface, or if you're going out onto the sclera, even onto the scleral surface as well, because you have independent control over each one of those areas. Now, since WAVE is keeping track of what you're doing on the back surface of the lens at any of those given locations, it will calculate what needs to be as a power value for the curve on the front surface that's matching up to that equivalent area that's on the back surface. This type of complex lens can be used for corneal sclerals, multifocals, OrthoK. And when you design up this lens, you don't really think of this in terms of things like a base curve and intermediate curve width and radius, or a peripheral curve width and radius, or even if you have a quadricurve, a pentacurve lens where you have even more of these independent peripheral curve systems, but really you conceptualize this more on how much tear layer clearance do I want between the front surface of the cornea and or sclera and the back surface of my contact lens in every one of those zones. And once you start conceptualizing in those terms, you let WAVE take care of the actual values that need to be generated by the lathe so that that's cut into the lens. So let's get into some of the examples here. This is my first example, and it's a 12-year-old Asian male. Spectacle RX, when he came in, he was wearing was a minus 250 with a quarter cell on each eye. He was a year old, and you can see I refracted him at 375 on the right and 3 1/4 on the left with the same quarter diopter cylinder, different axis, but same quarter the same quarter diopter cylinder. Health was good. He wasn't taking any medications or allergies. Everything else was basically non-contributory. He had no contact lens history. He's only been wearing glasses. And the parents who brought this child in were specifically interested in OrthoK for myopia containment. So let's take a look at the Pentacam and how we would utilize the Pentacam to evaluate this particular fellow's cornea. There's a lot of information that the Pentacam can give once you've taken the scan. So I'm going to go through each of the areas just so you understand a little bit more about what's being displayed. Where the arrows just popped up there on the upper left of this diagram, you can see there's a picture of the eye. That was the actual photo that was taken. And it's pointing to 20 out of 25, which is the out of the 25 rotational scans that were taken through the particular cornea over here. We're on the 20th one, and it's basically almost horizontal, and we're seeing that cross section displayed in the image, the large central blackened image there that the arrow is pointing to. That's the cornea. You'll notice that there's a highlighted red and green both on the front and back of that corneal surface, and what that is that the Pentacam is identifying the actual edge where the front and the back surface of the cornea are. Now over here on where these two arrows are pointing there, you'll notice there's this sort of green graphic on the right-hand side of that black in the box over there. And there's a vertical dotted line that's coming through the center of the cornea. And there's an elevated portion to the green part of the graph. And what that is the Pentacam is giving you information on how much light is passing through that, or in fact, how much light is not passing through that particular structure. That dotted line can be put anywhere. So if you had an opacity on the cornea, you would see that green graph on the right increase in size. But the cornea, you can see, is absorbing some of the light, not allowing 100% of it to go through. Down over here, we see another blip, and that's actually where the light is hitting the crystalline lens. You see on the very front surface where the horizontal yellow dotted line is, that's the very front surface of the crystalline lens. And then to a lesser degree, the rest of the lens is absorbing still some more of the light. Now down on the bottom middle over here, we have a graphic representing all of the structures that were measured. You can grab that and rotate that if you have interest. You could see that the red is on the top, which is corresponding to the edge that the Pentacam measured on the front of the cornea. Just below the red, you can see there's a green sliver. That's the back edge of the cornea. And if you were to turn this graphic so that you can rotate it, you would actually be able to see this space of the anterior chamber, and then the blue, which is representing the iris structure. Now, up in the upper right over here, that's basically sort of like your simulated K readings, and it's also giving you a graphic showing the principal meridians there on the left, and it's showing it's just a little bit to the left of straight vertical 90 and 270. It's about at 100, 110 degrees or so. But it's also giving you the amount of cylinder on that cornea. And then in the bottom right over here, we have a graphic displaying, in this case, the tangential curvature. But in fact, we really have a drop down, and we can actually display any of these particular values, whatever you were really interested in examining on that particular eye. Let's move on to this screen over here. This is the refractive display screen. And again, there is a lot of information here. So let's take a look at it and break it down. First, in the upper left, we have the front of the cornea. And that's fairly similar to what you would expect to get from a simulated K reading on a Placido disc-based topographer. It's giving you the simulated Ks, the amount of cylindrical difference that's on there. And again, you can see that graphic in the upper left of that box. Now, just below that is the back surface of the cornea. Anyone who's been using Placido disc-based topography is not familiar with this at all because it does not give us back corneal data, but the Pentacam is capable of measuring that. And so it's sort of the analog to what's on the front surface. We have sort of our simulated K readings there along with their corresponding radii, how much cylinder is on the back there. And you can actually see that the axis of the cylinder is actually closer to 90 degrees. It's really straight up and down over there. Now, just below that, there is this area that's basically the pachymetry area, and that's why I've circled the lower left of the colorful graphics there, where you have a pachymetry map. Since it measured the front and the back surface of the cornea, any spot that was within that measured area can be measured for thickness. Although it's displaying on the graphic on the large colorful screen there, you can actually put your mouse and click anywhere you want if there was one specific area, and it would give you a thickness measurement. Down at the bottom over here, this is less valuable for things like OrthoK, but it does have more academic value as well as possible implications for general structure of the eye, where you're taking a look at the volume of the cornea, the volume of the chamber, and there even has the value corrected for IOP measurements based on that particular data from the normalized study data. So you can actually put that in as a corrective value if you're concerned about following for glaucoma. More importantly to us, though, as OrthoK docs, we're much more interested in the horizontal white to white. In this case, it says it's 11.4 millimeters, and the pupil diameter, which it's measuring out, is 2.66 millimeters. Now, in the upper left of the four graphics there, that's the axial and sagittal curve map, and that would be the closest map that's really represented by the typical Placido disc-based topographer. That's the one that you'd be most comfortable with coming from that type of platform. On the right upper portion here, though, we have an elevation map. And the elevation is actually much more important to us from a fitting standpoint, because that gives us a sense of how is our lens going to actually line up on this eye. It also gives us the back elevation, which is actually more important for detecting some unusual activity, and the top of that list would be something like early keratoconus. So let's move on to this next screen. This next screen I've highlighted, and I've just put the right eye next to the left eye. We can see them simultaneously because this is exactly how I would sit down to design a lens. And I've circled the areas that are the most important to us as orthokeratology designing docs. You can see I have the simulated Ks with the amount of astigmatism that's being measured on the front surface of the cornea in the upper portion. And then in the lower portion, I've circled up the corneal diameter as well as the pupil size. Now, on top of that, I will bring up the wave screen. So this is the wave screen. I just want to go a little bit through the wave screen for those who are not familiar with this screen, because there's an enormous amount of data that's being displayed here. And to truly, really appreciate how this works, you really would have to interact with the software. So I've just taken still captures over here, and I've attempted to label this so you can really understand a little bit about what's going on here. This would start with the drop-down menu that's up at the top, and you would take that external software drop-down menu, go down to wave, highlight that, and it would bring up the wave screen that you're seeing here below. Now, On the bottom half of the left side of the screen here, you can, of each of the wave screens, you can see a gray and at its outskirts, the white area that's being represented or that's representing the corneal structure. Now, that particular corneal structure is the data that's taken directly from what was imported from the Pentacam data. So this particular graphic is not just a pretty picture. That picture is from all of the sagittal depth that you just imported from that particular cornea. On top of that, you can see that there's a blue arc, and that's representing the lens. Again, that is not just a picture, but that's a picture of the exact lens and the data that's used to create that, that would be fed directly to the lathe. So anything that you design into the lens is going to be shown there on that blue arc that's represented sitting on top of that cornea. Now, up on the top, there's a graphic relationship display between the back of the lens and the front surface of the eye. And the black line is what's representing the back of the lens. And just below that, there's a straight green line. And that green line is the data that's representing the cornea, but it has been simplified for us to think of it as a single straight line. Obviously, the cornea is not straight, it's curved, and it has all those different sagittal depths. But in order to design up the lens, it's easier for us to relate straight lines to straight lines rather than to curved surfaces. And so Wave has simplified that for us here. All right, so now I've gone ahead and designed up an OrthoK lens, and you can see I've done that on both sides. So let's just take a look and see what it looks like. The first thing is I've set my diameter of the lens, and in this particular case, I've designed up a 10.8 millimeter lens. You can design any lens to the nearest 0.1 millimeter diameter that you would like, and the range is from 8.6 out to 18. So anything within a tenth of a millimeter, you can specify the diameter. Now, on the graphic that's in the upper right portion of the wave screen, this is called the quad view. And the quad view is showing us graphically, color matched, just like the topographer, all of the various curves that we can understand exactly what we're going to be generating from a wave lens. So in the upper left, that's the front surface of the lens, and you can see I have a sort of a red donut on that one. On the upper right, that's a sodium fluorescein display, and so that's the theoretical model based on the fact that you have all of the topographical data as well as the back lens data. You can generate up what the fluorescein is going to look like. The lower left is the back surface of this lens, and you can see there's a sort of a central green and white donut around that with an area that's all blue around there. And then on the lower right, that's the corneal data that Wave believes this particular cornea looks like. And the reason for that is that the data that's collected by the Pentacam is then brought into Wave. And when you take one platform's data and convert it over into the other data, you can see a certain degree of change, subtle, but it's there in taking the data from one platform to the other. And so this is where the corneal representation is in the wave screen. I've entered the spectacle RX, and this particular left eye is the -3 1/4, -1/2 axis 150, which is what I had refracted him at. Those three check boxes there refer to the lens symmetry. The R stands for rotationally symmetrical, the G stands for geometrically symmetrical, and you can see I have that one checked, and the F stands for freeform, which would be a totally freeform or asymmetric lens. Down at the bottom, you could see it's pointing to the base curve. And the base curve in this particular case is the central portion of this lens. It's being displayed there as a discrete value, but as you go around the dimension of the lens, that actually could be changing depending on the symmetry and what you've designed into the particular lens. It also gives you the lens sagittal depth at the lens edge. So you can see the nasal of both the right and the left are being displayed over there. On the right one there, it's at 1948, and on the left eye, it's at 1941 microns of sagittal depth. Now, if you click the mouse in the upper portion, I would draw your attention over to number 1. You can see that there's a vertical black line that has come down over there, and that's the segment of the lens cornea relationship that we're checking. If you go over to number 2, you can see at a chord of 5.52 millimeters, we have a 47.1 micron clearance between the back of that lens, which is the black line, and the green line, which is down at the bottom representing the cornea. If we go over to number 3, you can see on the fluorescein pattern, the radar screen has a thin white line going to the right because we're checking out that particular semi-meridian. And along that, right at the tip of the red arrow, it may be a little difficult to see because it's right where the fluorescein is, there's an arc there that's representing that same black line because that's the exact spot that we're checking this information at. If you go down to number 4, you can see another black vertical line over there. And what that is showing you the exact spot between the line corneal relationship that we're going through. And if you look very closely, you can see the actual space that's between the back of the lens and the front of that particular cornea in that particular segment there. At number 5, you can see a summary of the tear layer clearance, which is 47 microns, the actual lens sagittal depth, which at that given spot is 473 microns, and it's at it's a semi-meridian, so it's a distance of 2.76 millimeters from the apex of this lens out to where we've just dropped that vertical line. Down in the lower right part of the wave screen is a lens summary. It's got the material there, the lens power, the base curve, the diameter, center thickness, and the edge thickness. This is a relatively simple lens, and so you can see that the numbers after the lens power and base curve are very close to 0. For example, on the lens power, it's 1.45 plus or minus 0.03. And the reason for that is because I have kept this lens relatively simple in terms of its power distribution, as well as the central portion of the curves of this lens, because I'm trying to generate a spherical curve out of my OrthoK lens onto the cornea. So let's take a look at the 1-month follow-up. On the top were the original Pentacam screens on this particular patient. And on the bottom, and I do apologize, but those are the scout measurements. You can see the upper half are the maps from the initial scout measurements, and on the bottom are the treated corneal measurements over there, and it has a very typical appearance that you would expect on a 3-diopter myope over here. And the reason that I have the scout as opposed to the Pentacam scans is only because logistically in my office it's much easier to do the follow-up ones with the Pentacam with the scout rather than to take them from that room and move them down the hall to get another Pentacam scan, but this certainly could have been done with the Pentacam as well. And so that would be sort of a start to finish. Very nice, successful OrthoK case, very straightforward. Let's get on to case number 2. This is a 10-year-old white female. Spectacle RX is about a year old, 3 1/4 sphere, and you could say I refracted a 350 sphere, so not a lot has changed. So myopic progression is not particularly the thing that I'm thinking about. However, you could see down at the bottom, the parents specifically brought them in for OrthoK. So we went ahead and designed up a lens for her. And in this particular case here are the initial screens that we had taken with the scans on the Pentacam over here. And I'm just going to go through the right eye for the sake of brevity here. So we have the 4 displays of the colorful maps over here. We can see the elevation is very boring, both on front and back of the eye. There's nothing very unusual about the curvature over here. And in terms of corneal thickness, if anything, she's got a fairly thick cornea. Pulled up a wave lens. Again, it's just a right lens, and I've imported that data directly in here. Once again, we have the black line representing the back of the lens and the flat straight green line at the bottom representing the cornea. And then down at the bottom, you could see my OrthoK lens. This is a little bit larger. You can actually see the space in the reverse curve area between the back of the lens and the front of the cornea. And in this particular case, I did follow her with the Pentacam. And so what we have here is on the bottom left was the scan from the 1-year exam. On the middle screen was the initial scan, and I created a difference map on the lower right there, so you can see the actual difference between when we had started and where we are today. Now, it also has the ability to display the right and left eye simultaneously. And in the upper right, you can see there, you just sort of mix and match the exams that you want to compare differences to. So once again, in the lower right, I've just matched up A, which was the scan of the right eye's treatment map 1 year, the 1-year examination, with exam B, which is the right scan that we had done initially. And again, it just shows the difference. You can just go ahead and match C with D, and then you would get the left one and see that difference map as well. Let's go to case number 3. This is a really interesting case and really kind of unique that was able to be done with the Pentacam. This is dating back to August 31st of 2005. So we're talking about 15 years ago. I was a 19-year-old white male, no spectacles, came in wearing disposable lenses, minus 750 myope. He was wearing them daily wear, 1 month disposable, and he was pretty happy with them there. I refracted him at a -8, basically a sphere in both eyes. Nothing unusual with his health. Everything else was doing great, but he was bothered by the amount of sheetrock dust that he would get in his eyes that he was working with all day long. And so he had asked about anything that might be able to be done better other than wearing protective goggles. And I had suggested OrthoK for him. So in this particular case, and again, dating back to 2005, I wasn't thinking about myopia control or containment. I was really just thinking about a way to correct his vision. So if we go back to 2005, those are the original topographies that I had taken back in 2005 in the upper left. Those were on the Scout. I've put up there both the curvature maps in the upper portion and then the elevation or best fit sphere maps in the lower portion of the Scout. And in the lower right, I've put the two two wave lenses that I designed for him back in 2005 with the right lens on the left side and the left lens on the right side. He achieved 20/15 acuity in each eye, and this here was from 2016. And so for 11 years, he had done absolutely fantastic year after year, not a problem at all. Kind of a boring OrthoK success story, nothing unusual going on with this at all. So in 2016, we had these maps over here, and they're just a little bit sloppy because this is at his year follow-up, and his lenses needed to be cleaned. But again, he still is 20/15 acuity and had no vision complaints. However, in 2018, he came in with these maps, and his acuity had dropped to 20/25, and he was still functioning okay, but he was a little bothered by the acuity, and I was a lot bothered by the maps because he had had fantastic maps for all of those years prior. So we talked about that, and I'm not going to get into exactly what was going on yet, but he came back a year later and his maps look even worse. Although he was 20/20 minus in each eye, I was very unhappy with the way these maps were playing out over here. And between the two, the left certainly looks worse. So the question is, what happened? Well, what happened is he no longer was working with sheetrock. He had graduated out of that, and he's actually working now with fire rescue. And in 2017 to 18 is when he started with that. And while he was doing this, what would end up happening is he'd be on call, get woken up, and wouldn't bother taking his lenses off to go out on the call because he didn't have any time to do that. And so you could see that the open eye wearing trashed my perfectly good orthokeratology treatment that had been working flawlessly for the previous 11 years. And it was only getting worse. So we had a long discussion in 2019 about what we can do to solve his problem. We had tried several things between 18 and 19, and you could see not only didn't they work, if anything, things had gotten even worse. So what I had decided to do was to go ahead and design up a very large diameter lens. So I put him onto the Pentacam and went ahead and got some scans on him. And on the Pentacam scans over here, I'm now measuring out the scleral data because I needed that elevation data, not just the corneal data, but the scleral data, so I can increase the diameter size of that lens so it lands properly on this particular eye. And that's represented on the left-hand side with those arcs by the colorful sections of the red, green, blue, and purple sections of those respective arcs. The gray is actually representing the corneal data. So what I went ahead and did on 10/30 of 2019 is I created a large diameter lens. I increased it. On the left, you can see he was wearing an 11.00 millimeter lens, and I increased it by 2.5 millimeters up to a 13.5 millimeter lens. My thinking here was by giving him a much larger lens, he could go ahead and wake up to go out on his call, not take the lens off, but the blinking of his lids will not push that lens around. I then went ahead and using some fine wave manipulation over here, equalized the base curves. So you can see on the left, my base curve is 917, on the right it's 919, so it's just about the same. I equalized the central sagittal depths so as to create the same relationship between the center of this lens along with his previous lens to the new lens. And then I created a totally asymmetric translimbal flange directly from the CSP data. So that's basically a flange on this lens that's asymmetric, that matches up perfectly with his particular sclera so that this lens will stay put where I want it to stay so as not to mess up his treatment. You can see here, this is a series of topographies. Back in 16, he was very good. In 18, that's when we started with fire rescue. In 19, that's when things went horrible. And a month after I had designed up the lens from 10/30, you could see 11/25/19, things were right back to normal again. They looked absolutely fantastic. So that really did solve his problem. So I thought I was a hero. His uncorrected acuity, 2015, fantastic. Refractive data was looking great. However, he complained that he was having trouble with removal, just a little bit, probably because he was unaccustomed to the size of the lens, but he was having a problem reading with the lens on. Thought that was a very interesting complaint. So I refracted him, and lo and behold, he was hyperopic with that lens on by 350. And with that, got him back to 2015. What went wrong? What went wrong is I took the original Pentacam data to generate this lens, but I did it on a treated OrthoK eye as opposed to a virginal cornea. And so Wave took care of the math, but it took care of the math erroneously. So I made a small mistake on there, not accounting for that. So I went back and designed up a second lens. With the second lens, you can see here, I went ahead and loosened the mid periphery a little bit of this lens. That was to help him get the lens off just a little bit. And I went ahead and added in a power for when the lens was on, not to change anything about his OrthoK treatment because that was perfect, but I gave the lens power another 3¼ diopters of plus, so that this way when the lens was on, he wouldn't have trouble reading. I also went ahead and did a subtle change to the central portion of the lens to compensate for loosening the mid-peripheral portion of the lens there. Again, I don't want to get into the finer points of Wave for that. That was just something I felt needed to be done. And so he was absolutely fantastic with those new lenses. So in conclusion, let's summarize what we talked about here. The Pentacam provides an excellent source of the topography to design software-driven lenses like Wave. We can do OrthoK lenses, but we can do a lot of other types of lenses as well. It captures a data over a much greater chord of the cornea than is possible with the Placido disc. So that really gives you peripheral corneal data that's actually a little bit more accurate, and that only works to your advantage in designing up a Wave lens. Additionally, if you have the CSP software, you can actually do what I just did on this third case and do the scleral profilometry and go ahead and design up a flange for the OrthoK lens as I did here. Of course, I do use this for all my scleral lens designs. Now, the Pentacam directly measures true corneal elevation data. It's not algorithm derived from the reflections off the tear film. And so, if anything, that argues probably for a little bit more accurate data. Tear film quality isn't an issue for data collection with the Pentacam. And in my opinion, that's probably one of the single greatest advantages the Pentacam have over every other device that's measuring scleral profilometry today, as well as obviously doing placido disc-based topography, because you get very, very accurate data, even if the tear film is not pristine. The Pentacam provides the data manipulation and display screen, so you can really get an enormous number of metrics about the cornea that is just not possible through any other means. And by doing that, you can see, yes, the anterior surface topography, both pre and post treatment for OrthoK, anterior surface topography for the sclera if you're designing up scleral lenses, but you can also see things that are going on in the cornea as well, such as even the back surface elevation data, which would give you information about early keratoconus. That pretty much concludes us for tonight. I'm going to go ahead and take some questions. And so hopefully Craig can cut on in with some questions there.
That was fantastic. Now, what's interesting to me is as much information that you covered and how clear it was. We have a bunch of questions tonight from the audience to answer. I would also suggest for those of you that have additional questions, if you type them into the chat box, we will attempt to answer those as we progress over the rest of our time this evening. Now, I'm going to break these down into some categories as I've been looking at the questions that have facing us. And I'd like to start, if I could, with the Pentacam questions first. And I think you answered this. One of the questions was, just to be clear, there's not any issue using the Pentacam for follow-up. And I think this relates to one of the earlier things you mentioned, that sometimes in your office, it was easier for you not to have to move the patient, and you use the Scout in that one example, but typically you would use the Pentacam also.
Absolutely, 100% true. The Scout in my office is sitting right next to the patient. The Pentacam is a couple of rooms down, and so just for the sake of logistics in my office, it's just as easy for me to go ahead, especially if I'm running behind, to get a follow-up topography done with the Scout. But no, absolutely no concern whatsoever in following the patient with the Pentacam scans. If anything, you can actually get much more data with the Pentacam scans than I can with the Scout.
Yeah, exactly. Another question was related to the tear film quality, but I think you ended up answering it a little bit later on in the closing comments, that it is a definite advantage of this type of measurement system, that one doesn't have to worry about putting in extra drops and worrying about the clarity of the tear film and the thickness of the tear film to get good captures. That instead, the instrument itself takes care of that.
Absolutely, 100%. In my opinion, that is probably one of the single greatest advantages, both for corneal measurement, but even for scleral measurement compared with the other profilometry devices that are on the market for scleral measurement, is that this does not rely at all on tear film. Whether the tear film was there, it's not there, it's in pristine condition, it's got globs of junk floating in it, it is irrelevant. You will still get accurate data off of the surface, and that is an incredible advantage in designing up the lenses.
Yeah, absolutely. So one more Pentacam question. This question, if I understand it correctly, is the Pentacam maps demonstrated different colors than what I'm used to seeing, like on the Medmont I have. Can you change those so that they simulate those same color patterns?
Okay, now the Pentacam scale that I had displayed all through here was an absolute scale. And it really is important to get accustomed to absolute scales, because then you can talk from one platform to another platform, whether it's on my Scout platform, the Medmont that many people might be using out there, or even on the Pentacam. However, on the Pentacam scaling of the absolute scale, the colors are slightly different in terms of the actual colors that he used. And so it does take just a little bit of getting used to seeing those same colors. The gradations that you can put between the colors it's entirely under your control, and you can create normalized scales as well as variable scales to display things a little bit differently or a little bit more similar to possibly what you're accustomed to seeing. But in my opinion, it's best to actually stay within absolute scales and just get accustomed to the slightly different colors that might have been used here compared to the MedMont. It doesn't really take that long to get used to that.
Okay. Here's another question relative to this. That what are the RX ranges treatable by OrthoK? And this is an OrthoK question, Ken. Is it
Okay.
dependent on corneal thickness?
Well, that's a good question. Since the vast majority of OrthoK studies that have been done so far have failed to really look at that particular metric, I don't know that I have any answer other than a speculative answer. In my experience, if I had to guess based on the responses that I've received, thinner corneas tend to over-respond compared to what I would expect. So what I found over the years is if I tend to have a thinner cornea and I'm targeting, for example, 3 diopters of myopia, I might end up, instead of ending with a uncorrected refractive status of maybe +1/4 or +1/2, I might end up a +1 or a +1 1/4 or 1/50. So anecdotally, I would say that thinner corneas do seem to over-respond a little bit, but I do not know that there's actually a direct correlation between corneal thickness and OrthoK
Okay.
results. Now, as far as ranges go, that's a really complex question, and it's dependent on many, many factors that are much more important than just what is the RX. So that one, I think that's beyond the scope of this lecture.
Okay. There was also another question related to the same thing. Do you use corneal thickness measurement to make decisions? And you commented on if and when you would do that. And of course, primarily the changes that are occurring in OrthoK are epithelial. They're not overall corneal thickness. So
Correct.
That's totally understandable. Okay. How incorrect would my measurements be using my K5 only for OrthoK? What percentage of the patients can I fit with the K5, which Keratograph 5?
Well, the Keratograph 5, I have had some experience with OrthoK designs on there. And as you know, the displays are a little bit different than what you're seeing on the Pentacam. But that is a Placido disc-based topographer, just like, for example, my Scout or the MedMont. Look, I've been using Placido disc-based topography to design OrthoK lenses for just shy of 30 years. It's a fantastic device. The point I think I was making here with the Pentacam is that you definitely have more accurate data because you can get essentially limbal to limbal measurements, which gives you peripheral data, which gives you a much better way to land the lens on the cornea. And the fact that it's not tear film dependent, I think, is an enormous advantage. So I think the Pentacam gives you a leg up on Placido disc-based topography for OrthoK. And the Pentacam also gives you all of these other wonderful metrics about the cornea, which, as we move forward in time and we start seeing some of the value of these metrics, they may be even more important to consider. For example, corneal thickness. Is that something that we need to be concerned about? If we have an unusually thick cornea, maybe it just doesn't respond, even though, as you said, Craig, and obviously I agree that OrthoK is primarily an epithelial phenomenon. maybe corneal thickness does play a role. So I
Sure.
think having the wealth of those additional metrics about the cornea, I think is going to be invaluable as we move forward. So I don't think there's anything inaccurate about using your keratograph. I just think the Pentacam is a superior device.
Okay. So we have one other question related to the comparison between Placido disc and Scheinflug, and that is, do you ever notice any difference in the simulated corneal readings? So
Actually,
SimCase.
Actually, what I did when I first got the Pentacam is I've been using the Scout tried and true trooper that it's been for a lot of years, a couple of decades. And I initially designed wave lenses utilizing both. I would design for a patient a right lens using the Scout and a left lens using the Pentacam, just to see how the wave simulations would be, how my results would be. And they were directly on target. So I would say that the correlation was incredibly good between them. So I think the simulated K readings that you get from the Pentacam are certainly every bit as good or as valuable as you would get from the Placido disc-based systems.
Okay. So confidence level in your experience really high,
Very,
either way.
not only is it high, but now I pretty much design all of the OrthoK lenses directly from the Pentacam. I may follow them with the Scout, but I design them from the Pentacam just because I have a great deal of confidence in the value of what I get on those scans there.
Okay. So I'd like to switch for a moment then to the wave questions. This first one is, and frankly, it's an interest of mine too. Why the 88 zones? Where did that number come from?
Oh, that you would have to go back to talk to Dr. Jim Edwards as
Okay.
to why he divided the screen or the that particular semi-meridian into 88. I mean, if you
Right.
think about it for a moment, lens designs have been historically divided into no zones with a monocurve lens.
Yep.
We went into 3 zones with a tricurve lens, and then 4, 5, and 6 curve zones with some of the more sophisticated designs, whether for keratoconus or even for more some of the more modern OrthoK design lenses out there, where we could put 6 curves on there. I don't think of it, nor have I thought about it in those particular zones for many, many years. The 88 sections that it's divided to just allow a much, much greater division of
Sure.
along that particular semi-meridian, so you can get the lens to line up the exact way you need to. Now, the exact math behind all of that, that's contained all within the software, and I don't think I would get too worked up about why 88 and not 89 or 100.
Right.
Uh, you know, if lots of OrthoK lenses out there vary from tricurve to 6 curves, and they're doing reasonably well, I think certainly we can get the lens to line up pretty nicely with the 88.
Right. Like for instance, it's pretty easy to understand the 15-degree segments, right?
Right.
I mean, that part makes a lot of sense. But the curiosity then is slicing it into 88, um, meridians going forward. So, anyways,
If
uh,
Craig, if I had to guess, that may have something to do with the inherent control that has to interface with the lathe.
mhm,
It may be a lathe limitation, basically a hardware limitation on the lathe side, that's really all that can be controlled out once the wave file is generated and is told, is telling the lathe exactly what needs to be
right.
cut.
But it's interesting you call it a limitation. I'm thinking, wow, there's 88 zones. 88 times 24, that 2000 is something that you mentioned is
Yes,
fantastic.
yes, it
Um,
is.
okay, so how do you select diameter? In one of your slides, you said, okay, so I chose a 10.8 millimeter diameter.
Correct.
Is that your formula? Is that built into the software? How does
No,
that come up?
no, nothing is built into the software, and that's why I was very quick to point out that Wave puts you in the driver's seat. There is nothing done for you. It's entirely up to you. Whatever your philosophy is, you can go ahead and imprint that into whatever you want to do into your lens designs. Now, in that particular case, Generally speaking, for my OrthoK lenses, I will measure the horizontal white-to-white measurement, and I will generate a lens that's generally 0.2 to 0.3 millimeters smaller than whatever the horizontal white-to-white is for an OrthoK lens. Now,
Hmm.
for a multifocal, for a single vision lens, for a scleral lens, I have a different formula. That gets into more of the nuances of designing with wave, as to what will work for you and why
Okay.
do you want this number or that number.
Okay. So in that vein, then, is there a default?
No, there is no default.
There's no default. So if you yourself decide that your standard default is 10/8, right? So for instance, in OrthoK, a lot of the lenses are 10/5 or 10/6, right?
Okay.
But if you like 10/8, I mean, that's kind of where you would start. Or
Well,
what you're saying is you don't start there. You're actually basing it on some of the data that you're acquiring and then going that 0.2 or 0.3 larger
or smaller. Right. That's
or
correct.
smaller, excuse me. Exactly.
Right. One of the things, and you bring up the point exactly, Craig, is that having most of the OrthoK lenses at, let's say, 10, 10.5 or 10.6 or whatever number they are, that's been a limitation that's been placed upon the users of that particular design, because that's what they're making the lens diameter at. Now, being that Wave is a free platform to design anything you want, in the early days, and the early days I mean like 20 years ago,
Mhm.
I might have gone ahead and designed up, well, I used a OrthoK lens that typically had a diameter of 10.3. So let me design up a wave lens of 10.3 because I'm comfortable with that zone. And what I quickly found is that no, this is actually much better to tie down to the actual measured data that we have off the cornea. And since I have total freedom to do that, I'm going to go ahead and freely do what I want to do. And so what I found is that in this particular case, for example, let's say you have an 11 millimeter cornea. If it's an 11 millimeter cornea, OrthoK lenses of 10.8 or 10.7 are going to work great. If you have an 11.9 millimeter cornea, I'm going to design an OrthoK lens that's up at probably 11.6 or 11.7. And that
Right.
actually goes along with the data that's been reported from some of the designs out there, that you really do want to have a diameter in an OrthoK lens of about 95% of
Yeah.
the horizontal white to white. So Wave has just given me that advantage 20 years ago, and I've been doing that, and my magic number is 0.2 to 0.3 millimeters smaller than the horizontal for the OrthoK designs.
Right. And it's a great formula, by the way, because if you think in soft lenses, if we had our druthers and could design the soft lens diameter, we'd be basing it on HVID and adding some factor to it. If
Exactly.
some of the scleral lenses, exactly the same thing. If you can modify the overall diameter, you're going to look at HVID first. And then the only difference is here, it's not larger than HVID, it's smaller than HVID to the number you just said.
Right, but actually, Craig, in my scleral designs, I didn't go into scleral for this particular lecture, but I do the exact same thing in terms of larger than
Yeah.
HVID. So I measure exactly what's there, and then I use my formula, and I'll generate out a lens that's 16.5, 16.6, 16.7, whatever, to the nearest tenth of a millimeter that's going to be related to that particular eye that I'm measuring for.
Yeah. Okay. Okay, great. So another lens design question. How often do you modify the optical zone size? So the people call it optic zone size, treatment zone size, whatever one would refer to it in
Right.
OrthoK, based on pupil size.
See again, that nomenclature is really tied to the typical traditional offerings out there. The optic zone size of an OrthoK lens that I've designed in Wave doesn't really correspond to any particular number, because again, I can design that down to any tenth of a millimeter that I would like. Uh, Plus, because I'm aligning the lens, historically, if you think about an OrthoK lens, or let's even go to a single vision lens, you might have an optic zone on a single vision GP that was, for example, 7.5 millimeters on a 9.2 lens. And then you have an intermediate curve width, but there's a fairly sharp transition between the back optic zone diameter and where the intermediate curve radius and that diameter begins. But on wave, because you have those 88 zones, it's really a continuous smooth surface. So where is the optic zone? You're designing up actually a continuous surface. So you can put that anywhere you would like, and wave does give you the control to do that as much as you would like. And so again, that's sort of a limitation by a pre-made design that doesn't really apply to wave. And so me going back to using control points to vary my quote optic zone size, the answer is I don't actually have to do that all that often because it's taken care of sort of under the hood within those 88 zones along each of those semi-meridians that are going
Right.
around the lens.
So then to build on that, does that mean that the reverse zone or reverse curve, however one wanted to refer to it, varies 360 degrees?
Sure. It all can vary 360 degrees, as well as outside of that reverse curve zone can vary 360 degrees as well.
Because of the segments and the 88
Correct.
zones we're talking about.
That's
Okay.
absolutely correct.
Okay. Well, that's fantastic. Ken, that takes care of the questions. We actually ran over our time a little bit. I really want to thank you so much for enlightening the audience. You sure as heck enlightened me. And it was a terrific presentation. I want to ask you, do you have any closing comments?
No, I don't really think I have anything else to add. Hopefully everyone was able to follow this. Again, this presentation was not really a how do I design within Wave so I can get successful results. And the reason I say that is I've been lecturing on Wave for 20 years, and I can tell you after lecturing for not for 1 hour and not for 20 hours, it's a lot more than that to really become masterful, having this type of variability under your control. And so you really have to change the goals of what you're really trying to achieve with a lens design here. And as you pointed out, Craig, different people might have slightly different philosophies as to how they want to apply that. And there's not a right or wrong answer here as long as you can get the results that you're trying to achieve. So this is really not meant as a wave training class. This was more as a here's what the Pentacam can do, here's what orthokeratology is about, and here's how Wave can really take the Pentacam data and apply that to OrthoK in a way that's really not possible through any other type of modality that's out there right now. And again, as you said, that does differentiate you out there as well.
Definitely. Well, I echo those statements. I think the information you provided about Pentacam, the information you provided about Wave, and the marriage between the two is fantastic. I want to thank the Oculus folks for sponsoring tonight's presentation. I want to thank the extremely high attendance that we had tonight on a Friday night attending this terrific lecture. Ken, keep up the great work, and hope to see everybody soon in the real world, not when we're all trapped at home. Good night, everybody. Thank you.
Good night, and thanks a lot, Greg. Bye-bye.